Hello, and welcome to the No Bad Questions podcast, where I try to learn in a conversational manner by sitting down with people who have interesting careers, important lessons to tell, or inspiring stories. I hope that you learn something too. If you want to support the podcast, please follow or subscribe on your platform of choice. You can also like or comment to boost the algorithms or share out to your network to make sure it gets more views. But ultimately, and what I hope you choose to do, is listen to the very end. With that, we'll start today's podcast. Hello, everyone, and welcome to this week's episode of the No Bad Questions podcast. My guest this week is Dr. Keith Bricking. Dr. Bricking is currently the Chief Clinical Officer at Premier Health in Dayton, Ohio. Dr. Bricking is a proven physician leader with more than 20 years of clinical experience, the vast majority of which is at Premier Health. He has served Atrium Medical Center in Middletown, Ohio as their CEO since January of 2019, the first physician to lead a Premier Health hospital, doing so during the COVID-19 pandemic. During his tenure, the hospital, designated a top workplace by the Cincinnati Enquirer, was recognized by HealthGrades as one of America's best 100 hospitals. So congratulations on that in 2020. Recently by U.S. News and World Report as a top 50 rehab hospital. In addition to his medical training and experience as an emergency medicine physician, Dr. Bricking has served in many leadership roles, among them president of the Miami Valley Hospital medical staff and medical director of the Miami Valley Hospital Department of Emergency Medicine. He has an unwavering commitment to quality and compassionate care, as well as to teamwork and collaboration. I've known him for 10 years, and I can vouch for that. Dr. Bricking holds a Bachelor of Science degree from Northern Kentucky University, earned his medical degree from the University of Kentucky, holds a master's in business administration from Wright State University's Raj Soin College of Business, board certified by the American Board of Emergency Medicine, and completed his residency in emergency medicine at Indiana University School of Medicine. So great career, great accolades. Dr. Bricking, thank you for joining me here on No Bad Questions.
Thank you, David. I'm excited to be here.
So first off, what is a chief clinical officer?
Great question. I think a chief clinical officer looks a little bit different in various systems across the country. But over the last 10, 15 years, it's been more apparent in the industry that physician leaders bring a different perspective to the C-suite, and not just running hospitals, but hospital systems. The vast majority of chief clinical officers, such as my position, oversee clinical operations for the entire enterprise or system. Mm-hmm. So we are a 5-hospital system and centered in Dayton, Ohio. We extend about 9 counties for our primary service area. And my oversight includes clinical operations, not just at the hospitals, but within our physician company and their offices. And with that oversight includes programs related to patient safety, patient experience, certainly the quality of care that's provided to our patients.
One of the things that I know I've seen, even just in my time in healthcare, you've probably seen it as well, but perhaps folks outside of healthcare don't see it as much, is healthcare. The knowledge in healthcare continues to grow. So I feel like the amount of specialization and subspecialization continues to grow. Is part of your role, at least, and maybe other chief clinical officers, to help integration and communication across those many specialties that are out there?
I think that's one component of it. Certainly when you have a physician executive or physician leader, that leader needs to certainly understand the vast array of services that would be provided within a healthcare system. It's important to be able to collaborate with physicians throughout the network. I think that the other piece of it is, having physician leadership that are spent decades of their lives taking care of patients at the bedside. They understand the value of making a connection with the patient. They understand how important it is that patient and their family is informed what's going on. They understand how important it is to provide cost-effective healthcare. They understand what good quality is when it comes to delivery of healthcare. And so as you think about my role and other physicians, I think that's the perspective that we bring to a table with other executives or administrators that may have gone up through a finance line or through a nursing line and have worked their way up through organizations as well as a supervisor, a manager, director, all the way up to organizational system leadership. Certainly, I agree with your point, David, that medicine is becoming more and more specialized.
Mm-hmm.
We joke a little bit amongst physicians is, at some point there'll be a fellowship on, people that are doing hand surgery only on left-handed people on their right foot or something like that. But the reality of it is we are learning more and more every day, every year about advances in healthcare and advances in technology. And a lot of the subspecialization in the surgical fields, the cardiology fields, some of the other medical fields, technology is requiring more and more expertise, more and more technical skills, and with that comes additional training and focus. And I'm sure whether it's you or one of your loved ones, you want to have that expert that has done this before and understands what the literature shows is going to be best practice, has a good technical skill set,
Mm-hmm.
and a great team surrounding them. So whether it's cardiology, whether it's general surgery, there is more and more subspecialization. It makes it really difficult for the generalists, right? There's an amazing group of physicians out there that have been doing it all, right? A general
Mm-hmm.
surgeon that's able to provide a large spectrum of not just general surgery care, but colorectal care, vascular care, or a cardiologist that do a vast array of services. But it's getting more and more difficult to be able to have those types of physicians because physicians in general, they want to become more of an expert in certain things. There remains incredible value for the primary care physician and the ED physician like myself. We like to say jack of all trades, but you've got to be able to recognize when you need help and where those limits are and how you can get the resources for those patients that really need that subspecialization or the additional expertise. I think it's going to continue to be more and more complex as we get more pharmaceutical research and as there's more therapeutic research and we have new robots and technology that we've got to be able to learn in order to provide minimally invasive type procedures to patients so that way they have a quicker recovery, a better outcome.
Do you see, I talked in December to an ED doc who'd gone back to clinical from the administrative side, and he was optimistic about technology, but still had some skepticism in terms of what, AI and technology was bringing to the table. Do you think that technology either today or going forward will have a role in what you said about trying to help to recognize when we need a specialist, trying to bridge the gap across specialties? Do you think technology is going to have an increasing role in that and helping docs and patients and whoever in the healthcare landscape to navigate this increasing complexity?
I think without a doubt, and I think that the healthcare systems that can embrace that technology and embrace it the fastest will have a leg up and an edge. I mean, the reality of it is our workforce shortages. It's a real problem. We knew with the baby boomers as they start to retire and that our number of healthcare personnel across the region, the state, and the country would continue to demonstrate more and more shortage. So if you have AI or technology that allows your workflows to become more efficient and honestly do things with less people, I do think it also will translate into higher quality care, hopefully even more cost-effective care. And I'll give you two examples.
Yeah, please.
One of the things, so right when I was finishing residency in the early 2000s or mid 2000s, I came to Premier Health, and we went on to the EMR. So we went on electronic medical record. And we used a little bit of an EMR where I trained in Indianapolis, but this was going to be full integration, right? And we thought that having everything on an electronic medical record would be fantastic because we would have access to all kinds of information and it would be more efficient. What we've learned is I'm not sure that things have gotten more efficient, and there has been an administrative burden that has been put on the weight of the shoulders of caregivers. And there's technology out there that will listen to an engagement between a physician and the patient, or an advanced practitioner and the patient, and collate that data into an electronic medical record for the physician then to proofread, and then put in, hey, these are my recommendations. This is what the treatment plan is. If you can decrease the amount of documentation time by 50% or 70% by technology, it allows me to get to the next patient. It allows me to focus more on what is that care plan.
Right.
And so I think that's a great example. I think there's a lot of things just from an operational efficiency standpoint. We think about the operating rooms, and there's a lot of moving parts in an operating room. But if you had technology or triggers that would allow you to know, hey, when's the patient ready? Hey, when's the room clean? What does the turnover look like? What's the surgeon doing in the next room, and are they ready? There's some operational efficiencies that can be built in with AI and technology. Another one I've heard of about twice in the last couple months with some of the partners that we're looking at aligning with is there's AI that will go into the electronic medical records and pick up important medical characteristics or data points that will be valuable for care delivery. So, for example, patient has a CAT scan and an ER done in one state, and then they go see their family doctor 2 months later and they get an x-ray of X, or they see a specialist that's not in one of the more mainstream EMRs. There's technology that's able to go through, link up all those electronic medical records, go through high-risk clinical criteria, and so that way when the primary care doctor is ready to see that patient, they can say, okay, yes, it looks like you've been diagnosed with an aneurysm. There was a CAT scan done 6 months ago that showed a nodule. Let's make sure you've got the appropriate follow-up with that. So I think AI and technology, we're at the very beginning stages of really leveraging it from a day-to-day standpoint, from a care standpoint. I do think it's a market differentiator, and I do think it's going to translate into better care, and hopefully take some of the other tasks off of the caregivers that are not necessarily value added. But we want the caregivers to be able to deliver that bedside care to the patients, or providing the medical recommendations. We don't want them spending all this time looking through a million charts if that technology can do it for us.
Right. For me, I share that optimism, just not even clinical, just, I want my doctor focused on my care, not focused on my paperwork. Right. And the paperwork has become a necessity in the modern age. And, I think, regulation, and some of it very good safety focused regulation and so forth has pushed some of that. The need to coordinate across all those different specialties, that's probably a necessity to have, a chart and paperwork to do that, but some paperwork's probably extra. And if we can get rid of that, streamline that, et cetera. And I was thinking when you mentioned, something sort of recording that patient provider interaction, putting that in the doctor proofreading, I couldn't help but think of what that might do to care. Even it's a thought I haven't had before, but you ever send an email and you go, boy, I wish I'd proofread or second guess that email before I click send. I'm wondering how much we would see providers when they read back what they said go, I should have been thinking differently, a different course of treatment, different whatever, or just whatever, given those interactions, because today it's sort of first party and move on. They document it and move on. Right. And if you're reading your own sort of interaction back to yourself, would you get that sent email effect? I'm going to call it that. I hadn't really thought about that before.
There probably are some bedside patient interaction things that you may become more aware of. We've created environments in our facilities where we may have someone in the room that's really focused on providing feedback to the bedside caregiver. Did you provide great eye contact? Did you introduce yourself appropriately to not just the patient but the others in the room? Did you respect confidentiality? Did you use language that the patient can understand, or were you talking doctor talk, right? And so there may be some opportunities to improve, again, your communication based on those types of observations.
What was it like in your bio? I read that not only were you the hospital CEO of a area hospital who got some awards in 2020, but obviously we had the pandemic outbreak. And without wanting to be political about that, because there's plenty of Monday morning quarterback now that we have a lot more data today than we did 3 years later, and all of us were watching Italy collapse and so forth. I remember living through that. But what was it like? You were in your first year, I believe, as the CEO, and here you are, this once in a lifetime, once in a century global pandemic is breaking out. What was that experience as a new CEO or newish CEO?
Yeah, you're right. So I just finished my first year when I remember sitting down with the COO of the hospital saying, "Hey, I heard about this virus over in Europe, and sounds like it's causing significant problems, but I'm sure we're going to be okay. It's not going to impact us." And then days go by, and you realize this is real, and we need to start really mobilizing some plans. If it does impact us in the United States, specifically in Ohio or the Midwest. And so, we've gone through some of these exercises in the past whether it was H1N1 flu, 10 or 12 years ago, whether it was, an Ebola scare 5 or 7 years ago. So hospitals, hospital systems, physician groups do have, disaster type drilling that they do on a regular basis. No one, in my opinion, really expected this emergency to last years. I think that, reflecting back on March of 2020, there were so many unknowns that I think everyone genuinely that I interacted with really did the best that they could do given the circumstances of the unknown, right? So you have no idea how this virus is being transmitted. You have no idea of the lethality of this virus. You hear inconsistent things on the news about the spread and the impact to other countries.
Right.
You have no idea of what the therapeutics are. There's no research. And all hands are on deck.
Right.
And so it really required organization at the hospital level, at the system level, at the regional level, and the state level. And I can tell you, my hospital sits pretty much Middletown. It's exactly in the middle between Dayton and Cincinnati. And those health systems in the greater Dayton area and in the Cincinnati area were fantastic about coming together, right? So it was all about, how do we do this together? It wasn't competition about, I want this patient or that patient, or you're taking that patient from me. It was, how do we keep our people safe? How do we take care of the patients? How do we create an environment where we're communicating practices, safety protocols, data? How many patients do we have? What is our capacity? And really, it was a 2020 and 2021 what was very administratively exhausting, but I'm very proud of what the healthcare system did. I have nothing but respect for everyone that really engaged in how do we best take care of patients. And that's from the environmental services people that are cleaning the rooms, the nutrition folks that are trying to make sure these people safely get fed, to the frontline caregivers. It's just, I couldn't be more proud of being a clinician, a physician through this as well. I did practice clinically. I have a full-time administrative job, but on the weekends and the evenings, I do want to continue to take care of patients. So I did that, and just the what our people did on the front lines, with not knowing what the personal impact of them would be or their families it really is heroic. And we use the term hero a lot. And it's incredible. I mean, we didn't know how bad it was. Unfortunately, as this virus continues to mutate, it is becoming less lethal, which is a great thing. But a lot of uncertainty, but a lot of teamwork, a lot of compassion for patient care. We've had tremendous community support. I mean, we had people that were sewing masks and putting together paper gowns that they were doing in their manufacturing plant and donating food to caregivers. It was really a remarkable experience to observe, and to lead a hospital through that, and that community through that was really an honor to be in that seat, regardless of how hard it was, to myself personally.
And you mentioned that during that time you're still trying to do some bedside care shifts, and are you still today? I mean, so you've moved from that role as CEO of a hospital to your chief clinical officer role. Are you still taking care of patients from time to time?
I am, not as much as I'd like, but I am still working in the emergency department on occasion. I actually worked an ER shift this past Monday. I've had tremendous support from Premier, encouraging that me to keep those skills. And I appreciate my family being able to make that sacrifice, because it does end up being an overnight shift or an evening shift or a weekend shift when most of the administrative day-to-day stuff is those meetings are over. But there's nothing like, from an ER standpoint, having an undifferentiated problem and working with a patient and the family to kind of figure out what the best treatment plan is, and making that connection. And so I don't see myself ever being able to give that up.
What drew you then to the leadership side of healthcare over the years? You've sort of, I guess you could say, slowly at first and now fully gone over from the bedside to the administrative or the leadership side. What drew you towards that side of the shop?
Yeah, I realized early on in my clinical practice that I wanted to do more and I want to have a bigger impact. And I also really enjoyed working with teams. The emergency department is a very operational environment. Patients certainly are coming in to seek care, but from an operations standpoint, how do we get that patient to the provider quickly? How do we make sure that patients are getting the test results quickly? How do you make sure the patient gets registered appropriately? How do you make sure that the patient then gets passed on back to being discharged with an appropriate care plan or admitted to the hospital? And I've just really became interested in how do we make this more efficient? How do we make it more patient-centric? And, one thing led to another. And I realized I can have a bigger impact. In an ED shift, I might see 25 patients. In a week, I might see 100 patients. In a year, I might physically touch 5,000 patients. As a medical director, as a chair, as a hospital administrator, or in this role, you have the ability to impact hundreds of thousands of lives. And that sounds grandiose, but in reality, the entire care team, whether it's a bedside caregiver or somebody in the C-suite, we're all committed to that patient care. And for me personally, I knew I can make a bigger impact by working with others on the teams to deliver care more efficiently and hopefully with higher quality and a more safe environment. The other piece I really enjoy is I enjoy working with physicians. I understand the sacrifices that physicians made to get
Mhm.
into medical school and to get through medical school and get through residency and start a practice and integrate into that. And I enjoy building programs with physicians. I enjoy um, learning about their fields. I enjoy having conversations to hopefully help them reflect, why did I go into medicine in the first place? Healthcare is a business, but most people that went into it really went into it so they could take care of
Right.
patients. And physicians have ideas of the best way that we can take care of our patients, and I have the ability to link them together with the administrative support. I also have with my team, have the ability to hopefully put together a team where we can just provide care in an enhanced way. So I just really enjoyed, the working with different teams and hopefully, um, encouraging them and empowering them and hopefully providing influence so that way they can also drive towards that higher quality care for the system and our community.
Thank you for that. I want to back up
Sure.
a minute. We talked about tech, perhaps, hopefully, helping with staff shortages. And I know that you are I think it's part-time, but you're a professor as well at one of the local medical schools. And we do have this looming shortage of really every job, but particularly physicians, particularly because it takes so long and so much sacrifice to train a physician. So the tech might help, but are there things that you're seeing, maybe not just yours, but other medical schools, the training apparatus for physicians do in the United States to try to help solve for our physician shortage?
I think from a physician standpoint, there is a concerted effort across the country to increase the enrollment
Mm-hmm.
and increase the number of residency slots across the country. The reality of it is the future of healthcare is not just going to be dependent on the physician. That captain of the ship mentality, it needs to evolve, and it
Mm-hmm.
has really evolved over the last 10 to 15 years. Care delivery has truly become a team sport. And as we continue to educate physician assistants and nurse practitioners from and really empower them to work at the height of their license of independence, physician oversight when appropriate, but we've got to be able to multiply the care team. And so from a provider standpoint, I think having nurse practitioners and physician assistants are fantastic. I think they do a really good job of care delivery. I think that again, they work closely with physicians, and you're not going to have enough physicians to be able to take care of all
Mm-hmm.
patients. So it's going to be important that those teams continue to evolve. There are subspecialized things that you need a physician that's gone through residency or fellowship to have training for. But that's one narrow focus of the care delivery. The advanced practitioner, the PA or the nurse practitioner can do other parts of that care. They're not necessarily going to be, they may be assisting in the operating room or assisting in the cath lab, but really you're going to need physicians for some of those high technical skilled things.
Mm-hmm.
But there's no reason why we shouldn't be able to build up the care teams.
Yeah.
I think pipeline's important. What healthcare systems across the country are doing is they're working with the local vocational schools, they're working with high schools, they're working with community colleges, they're working with the undergrad programs, they're working with STEM schools to figure out how do we redesign the care model. Does it have to be one nurse for 4 patients? Could it be a nurse and an LPN for 8 patients? Can we, again, can administrative tasks be done with other members of the care team so the registered nurse can be focused on bedside care delivery of the patient plan? How do we bolster the number of under high schoolers interested in medical tech and radiology technology, X-ray techs, MRI techs, physical therapists, pharmacists? You can really make a good living in all aspects of that. And it's going to be critical for care delivery as we move into the future. I was at a recent healthcare summit, and one of the things that they were talking about was the role of the pharmacist.
Mm.
And across the country, we're starting to see pharmacists embedded in primary care practices. And they're serving as a resource to optimize the patient's medicines, make sure that they understand the dosing, making sure that they understand why they're taking it, and also making sure it's cost effective. When you're seeing a kidney doctor and a heart doctor and a GI doctor and a primary care doctor, all those doctors may be prescribing medicine. Some of them could be duplicative. Some of them could have side effects with each other. How do you leverage a pharmacist to be able to look at all of those things and work with the primary care provider in order to be able to optimize that care delivered for that patient? Care coordination, social workers, a lot of physicians, again, critically important to the care team. But if you don't have somebody that is communicating with that patient, their family, their caregivers, their loved ones, to know what kind of are they living in a food desert?
Mm-hmm.
Are they able to get the nutrition that they need to take care of themselves? How do they pick up their prescriptions? How do they pay for their prescriptions? Do they have transportation? Are they sitting next to a bus line that can take them to their doctor? How do we connect them to a doctor? So all those people are critically important, and we need to encourage people to learn about all aspects of those fields. Physicians are important, but the entire care team is really needed in order to be able to provide care.
I love that perspective, and you call it an evolution, and there's some elements in there that are probably evolving and innovative. And there's an awful lot of parties out there in the country and in the world, though, that want to move faster and they want to disrupt. They want a revolution in healthcare. And I know before the call, that was this topic. Then I think it segues us nicely, which is how do hospitals fit in with all these people that want to, and entities and organizations that want to disrupt healthcare? Because I think some of that evolution can be very sustainable. Organizations evolve, they work towards doing better, they improve over time. But evolution is not fast, both in the literal sense or in the figurative sense here. So disruption is about moving a lot quicker. And well, I guess, do you even agree that healthcare needs to move faster? I won't call it disrupted, but I'll say to move so much faster. And B, what would your perspective be? Because regardless of your perspective, obviously others do think it needs to move faster. And does the hospital have a place in that, or is the landscape gonna move under hospitals' feet, if you will?
I think hospitals need to embrace the disruption going on. I think the key for healthcare, specifically as it relates to hospital systems, is we've got to find a way to partner, right? So you have disruptors, you have private equity that comes in and wants to invest in some aspect of the business, or you have a technology company that's trying to get the foot in the door on some sort of product that may translate into more efficiency. We've got to figure out how we can partner with them versus compete with them. The challenge for hospitals and healthcare are finances.
Mm-hmm.
And so, the problem in 20 and 21 was the challenge with COVID, and then the beginnings of this workforce revolution where people were leaving the workforce or leaving the bedside or staying home or retiring early or what have you. But coexisting through 2022 have been financial pressures because of the expense of labor and the expense of supply chain needs. And the reality of it is most hospitals are dependent on the government because such a large segment of their patients are Medicare and Medicaid. So we have healthcare systems that have higher expenses that may be out of their control: workforce, supply chain, pharmaceuticals. All those things are going up. You've got reimbursement that is flat or going down. You've got a segment of commercial payers that are also either shrinking their reimbursement or appropriately going into the value space with hospital systems. And those cost pressures are resulting in, I've heard anywhere from 50 to 60+% of hospital systems end of the year with a negative operating margin. I've heard as high as 80%. Yep. I don't know what the exact number is. Certainly greater than 50%.
Right.
So you're talking about an industry where there was already margins that were low, 1 or 2 or 3% operating margin across healthcare systems is a good place to be, so you can reinvest back into your system, to all of a sudden having an environment where there's going to be hospitals that have to close down because of the cost of care. So coming full circle, we need to figure out how we provide more cost-effective care. And sometimes when you have private equity, you have innovators or disruptors, they have the capital to come up with an investment to provide more efficient care or a lower cost of care. So I think that hospital systems that do that the best are likely to succeed the best. Because Medicare and Medicaid, the cost for healthcare, that reimbursement is not going to increase. It'll probably decrease over the next 5, 10, 15, 20 years.
Right. And I know over the last decade, a huge portion of where a lot of people thought that ability to get out from the cost pressure was going to come from was scaling via merger. And I feel like the mentality is changing on that now for two reasons. One, public pressure. People don't want their hospital to be part of some big corporation. And two, I think, so that's, I guess, outside of healthcare looking in, people say that. But then inside of healthcare, I think there's a lot of, white papers and so forth where a lot of that M&A didn't yield the savings that people thought it would. So do you, just to your opinion, not asking you to speak for your organization, but do you feel that merger is the only way forward, or can, through strategic partnerships and innovation and technology, can the mid-sized shops, 3, 4, 5 hospital organizations survive in the coming decade?
Yeah, I think they can survive, and I think it has to be exactly what, as you illustrated. It's going to have to be strategic partnerships. It's going to have to be the determination of what services you can or cannot provide. It's going to have to be alignment with the community of, again, care delivery. I do think industry-wide, there's going to be acquisitions that will have to take place just because of, again, the financial cost pressures. I think there are some larger systems that have found some economies of scale by centralization of, billing and coding and some of the back office things. But the reality of it is, everyone, like, we have a lot of pride in the care that we give at our hospitals, and we want the cutting edge technology, right? We want the best, cath lab equipment. We want the best interventional radiology equipment. We want the robots. Those things are very, very expensive and do not often necessarily translate into more revenue.
Right.
So how do you balance being cutting edge? How do you validate that truly does provide a better outcome? How do you still connect with the consumer? Because we are going to have to become more consumer centric. And how do you still maintain a break even or a slightly positive operating margin? It is a very complex problem that is not going to go away anytime soon. We talk a little bit about trying to meet the consumer where they are. I think that telemedicine is just another example of a success that was put on the fast track because of COVID, and now it's translated into tens or hundreds of thousands of visits that can be done through your phone or through some sort of electric platform, and we can still provide good care that way. And so, how much more of that can hospital systems and the physician entities and do in the future? I think that's going to be critically important.
Yeah. And And you mentioned in there about deciding what services to provide to a community. So let me take that and zoom way out. And this might be one of our last questions. I'm gonna zoom way out, and I don't know if you've heard this sort of mantra of people criticizing the U.S. healthcare system, is that it's sick care. It's sick care. And I read the other day, and I hope I attribute this correctly because I don't want anybody to feel like I'm stealing their quote, but they say it's not sick care, it's curative care. And what's wrong with that? We are indeed designed to, our health system mostly, to take care of somebody when they get sick. We're not designed to make sure they eat right and don't have lead paint in their home. And that's not what our health system is designed for. It's to cure people as best we can when they get sick. And so the question that evolves from that, or emerges from that for me, is should hospitals, or even the physician offices that are so often employed by hospitals today, should they be the ones trying to solve for the philosophical underpinning of that question, that it's sick care? Should we be the ones that have to go out to the home and have to do all these different things to make sure people live right? And I think that ties to the emergence of concepts like social determinants of health and value-based care. And I get all those programs, but what I struggle with is, should that be us? Or should that be public health? Or should that be some as yet uncreated industry? And so you've got this role that's bringing together all these clinical components for your organization. What do you think about where a hospital really should and can fit in that picture of sick, with air quotes for those who are only listening to audio, versus wellness?
Yeah, that's a great question, and a very complex one, as you outlined. Clearly, for what you described as the sick care, the curative care, we call the acute care. Mm-hmm. We are always going to be in that acute care space, mm-hmm. right? You've got to have a place from a hospital standpoint. You have to have a place where a patient that has an immediate need needs to be taken care of. And you have to have an environment whereas if somebody is battling a diagnosis, whether it's knee pain and they need a knee replacement, or cancer and they need an infusion, we've got to be able to provide a safe, high-quality environment to be able to care for those patients. Mm-hmm. I do think that there is a role for healthcare systems in wellness and prevention and social determinants mm-hmm. of health. I don't think there's consensus. There's definitely not consensus. There's some. Our job is the hospitals. Mm-hmm. Our job is our primary care network. Our job is our home health network, or what have you. But I think there is a role. Mm-hmm. I mean, and there's multiple reasons why. If patients live better, healthier lives, then that will reduce the cost of care for patients. It'll allow us to be able to enhance the acute care offerings for those that really need those things that are incredibly expensive. I think we're going to have to partner with employers, with insurance companies, with public health, in order to really dig deep into how do we create an environment for patients to live healthier lives. It is not easy. I mean, we have communities surrounding Dayton, Middletown, and Troy that are incredibly poor, unfortunately, and they don't have transportation, and they are food deserts. And those individuals are just trying to live day by day, right? Mm-hmm. They're just trying to make sure that they can put food on their table and pay their bills and hopefully get to work. And they're not focused on eating the salad for lunch or dinner, right? They're not focused on, they're paying the bill. Should I pay $50 for this prescription, or should I pay for the electric bill this month? I mean, that's a reality. And unfortunately, that's a person that potentially may end up in your hospital with a heart attack that 5 years earlier we could have prevented. Right. Or if they had gone and gotten their annual well visits, and they had whatever the screening is to kind of prevent the breast cancer or the colon cancer, had they gotten that, you could have prolonged their life. So we have a role. I don't know how we do it. other than continued conversation, dialogue. You're going to need community resources. These things are expensive, and it's not about reimbursing a hospital, reimbursing a company. It's about how do you invest in the infrastructure to make this successful. And even in some of those socialized medicine environments, they still struggle with the social determinants of health. They many of those countries also have tiered system of healthcare delivery. And so I don't know what the secret sauce is, but it's going to take a lot of collaboration, effort, energy, and talent in order to be able to solve it. I do think there will be continued cost pressures from government payers and from commercial payers working with employers to provide more cost-effective care. And cost-effective care is prevention and wellness.
Yeah.
And so I think as this evolves, I think we'll do a better job in that space as well, because the finances are going to also drive it.
Yeah. No, that makes a lot of sense. And I appreciate you weighing in on that sort of more weighty question at the end. So, Dr. Keith Bricking, thank you again for coming on. Talked a little bit about your care, your career, leadership. We talked about care too, as part of our conversation on COVID, and then some bigger topics on disruption in healthcare. So once again, thank you for joining me here on No Bad Questions.
Thank you, David. It's been a pleasure.